Good morning. I'm Jan Dick with the Minneapolis Heart Institute Foundation, and we're pleased to kick off, we're calling it the spring semester of Grand Rounds. So we have rain on cue for that, so we can pretend that it really is spring. So we're really pleased to have Dr. Jesse Manunga with us today. He is a vascular and endovascular surgeon with the Line of Health MHI, and has been in the practice for 10 years. So do I have that right? And during that time started Abbott Northwestern's Endovascular Complex Aortic Aneurysm program. So today he's going to give us the current state and the future direction of the management of patients with acute aortic syndrome, and complex aortic aneurysms. So welcome.
Thank you so much. Can you all hear me? All right, I can speak louder, so if I wanted to, if need be. Thank you for that kind introduction, and good morning to everyone. I have no disclosures related to this talk. The story of endovascular aortic aneurysm repair really starts with a man from Buenos Aires, Argentina, who started to doing animal testing, and then in 1990, took a stent, mounted it on a balloon, and then delivered it through the femoral artery in a high-risk patient with an infrarenal abdominal aortic aneurysm who is not a candidate for an endovascular repair, for an open repair. He would go on to do fix five more patients, very high-risk patients, very eager to share his experience with the rest of the world. They wrote a case report, submitted to multiple journals, including our own journal, Vascular Surgery. This was rejected because the idea at the time was thought to be very radical. In fact, he submitted his case report to multiple journals after that. It ended up being rejected. In 1991, he finally submitted to the Annals of Vascular Surgery, and the article was accepted. But at the time, because it was considered so out of mainstream as a treatment modality, Dr. Bergen, a prominent surgeon from La Jolla, California, was chosen to write a commentary about the procedure. And I love this commentary because it was so forward-looking. It says, "It has been said that the essence of great art is simplification. In working out the details of transfemoral exclusion of abdominal aneurysm from the aortic stream, Dr. Juan Carlos Perotti and his colleagues have simplified aortic surgery. Thus, their work is truly artistic as well as scientific. There is no doubt that the procedure achieves its purpose. Predictably, it'll be offered first to patients who are at prohibitive risk for conventional aortic surgery. As this experience grows, it'll be offered to patients who are good surgical risks, even those with aneurysms smaller than the ones conventionally requiring surgical repair. During this time, complications will occur, some of which I cited in this initial clinical experience. As every interventional procedure has its own complications, new problems will arise. Opposition to the procedure will be mounted. In vascular surgery, no change for the better has occurred that wise and good men have not opposed. Now that this initial barrier is broached, new applications including transluminal distal bypass are predictable. Such change is inevitable." I'm sure our fellows are looking today and wondering, what do you mean? What do you mean by saying that transluminal distal bypass is predictable? This is routine now, but it wasn't back then, and it was something that was really, really considered very radical. Dr. Perotti was invited by Dr. Frank Veef in 1992 to come to New York, and for the first time in New York, in Mount Fero Hospital, which is now Mount Sinai Medical Center, they performed their first endovascular aortic aneurysm repair. Obviously, this thing now caught fire. A lot of physicians started working with industry. Industry gained interest into this to kind of perfect the stent design and implant it in the patients. Needless to say that multiple publications inundated the cardiovascular literature about the technique, and 14 years after the initial publication from Dr. Perotti, we had 3 randomized controlled trials from high-end journals, including New England Journal of Medicine, The Lancet and JAMA, all of them showing that compared to open repair, endovascular aortic aneurysm repair offers several advantages, including decreased operative death, operative time, need for transfusion requirements, and mechanical ventilation. In 2011, there was a publication in the New England Journal of Medicine, which sampled vascular surgeons across the United States and looked at all patients treated for electively with infrarenal abdominal aortic aneurysm from 1999 to 2008. As you can see here, there was a 36% reduction in mortality, which at the time was considered the most drastic reduction in mortality of any surgical procedure. A careful analysis of the patients showed that greater than 70% of patients were treated by endovascular means. In fact, by the year 2008, for the first time in the United States, endovascular repair has overtaken open surgical repair as the treatment of choice for elective treatment of choice for patient with infrarenal abdominal aortic aneurysm. Today, this number is close to 95%, and mortality for patients undergoing elective EVAR is a 1% or even less than 1%. I review our own data here. I think in 2019, we had zero mortality in patients undergoing elective repair in 1 year for infrarenal abdominal aortic aneurysm. Surgeons, for obvious reason, have tried to use this application, expand the application of endovascular treatment to include patients with trauma such as aortic transection, aortic dissection, penetrating aortic ulcer, intramural hematoma, and other rare conditions such as coarctation of the aorta. I wanted to talk a little bit about classification of the aorta. I believe we all know we have two classifications, and the Stanford classification, which goes with type A and type B, which is the most commonly used, and we have the Dr. DeBakey classification, which is less commonly used today. Recently, the Society for Vascular Surgery, in conjunction with the Society for Thoracic Surgery, came up with a new classification of type B aortic dissection, which breaks down essentially type B aortic dissection into 11 zones, and this is mostly based on a primary entry tear. And it makes sense because this guides our therapy. Risk factors for aortic dissections are listed here and include hypertension, intramural hematoma, connective tissue disorder, pregnancy, and polysubstance abuse. Connective tissue disorder are of particular importance to surgeons because they pose a different challenge in managing this patient due to friability of tissue at the time of surgery. A lot of the stuff that we know today about aortic dissection come from the International Registry of Acute Aortic Dissection, or IRAD, which the Minneapolis Heart Institute is part of. And a lot of the statistic and the data that I'll be sharing with you today has come from papers that have been authored by one of our own, Dr. Kevin Harris. All things taken together, patients with type B aortic dissection are usually 10 years older than those with type A aortic dissection. Yet type A aortic dissection is considered a more lethal condition with about 1% mortality per hour in an acute setting. It has a pre-hospital mortality of about 20%. Left untreated, about 2/3 of the patients will be dead by the end of the week. Here's another data from IRAD showing that patients with type A aortic dissection managed medically have a greater than 60% mortality. However, when they manage surgically, mortality is about 26%. Patients with type B aortic dissection who are managed surgically have a roughly about 26 to 28% mortality, and those who are managed medically have about a 10% mortality. For this reason, traditionally, type A aortic dissection has been considered a surgical emergency and has been repaired or treated with a replacement of the ascending aorta or hemi-arch, as you see here, while type B aortic dissection is being treated with anti-impulse therapy. But is it time really to rethink of the way we are treating patients with aortic dissection? The truth is limited aortic repair, be it a just ascending aorta or even a hemiarch is associated with about 70% occurrence of late distal aortic complication, including rupture, aneurysmal degeneration, malperfusion, and the need for secondary and sometimes tertiary intervention. Patient with type B aortic dissection treated with anti-impulse therapy have a 30% mortality at 5 years, and survival in long term is less than 50%. The question then is this really acceptable or justifiable even in an endovascular era? How can we then harvest the advantage of endovascular therapy to increase survival of patients with aortic dissection? Here's a case of a 67-year-old male that presented to an outside institution with mesenteric ischemia. This patient was transferred to a physician up north in Minnesota was trying to come from the arm to stent the superior mesenteric artery under conscious sedation when the patient started complaining of significant abdominal pain and chest pain radiating to the back. The procedure was stopped and the patient was admitted to the hospital for observation. Overnight, the pain continued. A CT scan was obtained, which shows a significant type B aortic dissection. This patient was transferred to an institution only 3 weeks after I had started practice here in 2011. I believe it was end of July of 2013, rather, and I was on call. And after reviewing the CT scan, I decided to stent the patient, place a thoracic stent graft distal to the subclavian artery, and I went on and also stented his superior mesenteric artery. 6 months later, the patient presented for a follow-up. You can see that his aorta is completely remodeled, and you do not see a sign of aortic dissection. This is our current approach now for the management of patient with type B aortic dissection. Once the patient is diagnosed with type B aortic dissection, we treat them with anti-impulse therapy or antihypertensive medications. We rescan this patient within 48 to 72 hours. The patients are then stratified into either high risk or low risk. Low-risk patients are rescanned within 4 weeks. Again, if there's no event or no change in aortic diameter, they are observed for another 6 months with another CT scan. And if the aorta remains stable, we scan them again on a yearly basis. High-risk patients are patients with total aortic volume of greater than 40 millimeter in the greatest diameter, or those with an entry tear of greater than 15 millimeter in diameter, or patients with flow lumen to true lumen ratio of greater than 60%. These patients are also scanned again in 4 weeks, if at all possible, and are offered TEVAR with the goal of landing 2 centimeter within a normal aorta. Here's a patient, a 42-year-old, I believe, patient who was working in a warehouse lifting heavy object when he started complaining of severe back pain. He was taken to Methodist Hospital and was noted to have a type B aortic dissection. He was treated with anti-impulse therapy and went back to see his primary care, to see his vascular surgeon, who's one of the fellows resident that I trained with at the Mayo Clinic, and at the time he was complaining of claudication of the left lower extremity. He was referred to us for evaluation in our clinic. And how would you manage this, Ben?
Well, it looks like the common iliac on the left is almost completely thrombosed once we get down there. It looks like there's a little bit of flow coming through, but I can see why you'd have claudication. So the axis on the left, I think, looks okay. So I think he would benefit from stenting of left common iliac.
Okay, so you can stent left common iliac, certainly that's an option. You can do a femoral crossover, right? It's not having a claudication on one side. In this case, given the patient's age, I decided to stent his proximal aorta after doing a left carotid to subclavian artery bypass and plugging the thoracic aorta, plugging the the subclavian artery with an Emplatz plug. We use IVUS in this case to ascertain that we are in true lumen. You can see now we are in true lumen. And over on the other side, you see the completion angiography. We do not balloon these cases, balloon the stent in these cases because of high risk of retrograde aortic dissection. This patient has been followed up. This is a CT scan that, in fact, that we got last week here in clinic. You can see that his aorta is now completely remodeled, and he has a still flow in a false lumen, but this is limited to the common iliac artery on the right side. What we have done with this patient, we have essentially, we could have managed him medically, but if we'd done so at age 42, he would probably progress to develop a thoracoabdominal aortic aneurysm and end up with a bigger operation. By placing a thoracic stent graft proximally, we have induced remodeling of the thoracic aorta and even the visceral aorta. Now we've converted to a more simple operation. This patient can be treated with an EVAR or an IBE or even an open repair, which will require just an infrarenal abdominal aortic aneurysm repair. The Abbott Northwestern program was started by Dr. Kevin Harris before most of us really arrived here. Dr. Harris has been very welcoming to us, and we're very appreciative of this. In 2014, Vascular Surgery pushed to be involved in all aortic dissection, including type A aortic dissection. We also push at the same time that patients should have either an aggressive hemiarch, but we prefer that the patient have a frozen elephant trunk. How did we arrive here? We arrived here because we were seeing a big number of patients referred to us for repair of a thoracoabdominal aortic aneurysm that also had the arch that was ruptured, and we did not have a landing zone distal to the subclavian artery. And these patients were requiring a redo sternotomy and a frozen elephant trunk before going back to do any other endovascular procedure. We had a meeting with cardiac surgery, and obviously the pushback was there for obvious reason. Why should we be offering these big operations in patients who are so sick to start with? What would be the risk of stroke and paraplegia? We believed that these changes will lead to improved outcome of patients, and we're fortunate enough to gain their approval. As you can see here, the job of vascular surgery intraoperative in patient with type A aortic dissection is really simple. We obtain access in the femoral artery, we push the wire up, and we'll do a intraoperative, we do an IVUS to ascertain that we're in a true lumen. We then land a stent proximal to the subclavian artery. Our stent graft then is sutured by cardiac surgery to their graft. And what we're hoping to see, as you can see in this case that was fixed by Dr. Ben's son and myself, is remodeling of the aorta so that we have a landing zone so that even though the aorta and the visceral segment is still dissected and this patient is only 48 years old, that in the future we have a chance of offering this patient an endovascular repair with fenestrated and branch endograft. In 2021, we decided to review our own data to see have the changes that we've made really made any difference in our program. We compare patients that were treated before 2015, the time before which we introduced these changes, and patients that we treated after 2015. As you can see, patients treated after 2015 had more extensive repair, including aggressive hemiarch and distal stent graft placement or a frozen elephant trunk. These patients were also more likely to have IVUS, completion angiography, and left renal artery stents. So surprisingly, though, the rate of stroke and even rate of paraplegia was lower than before 2015. And if you look at patients with type A aortic dissection, looking at this Kaplan-Meier curve, 3 years, there is significant improvement in survival among patients with type A aortic dissection. For patients with type B aortic dissection, although there is a trend towards survival at 3 years, this trend did not reach statistical significance, and I believe this was due to a small sample size. And I believe as we continue with this program, we will see this improvement in mortality. Most importantly, though, we're looking at overall mortality before 2015. Mortality in our group here at MHI, in our program here at MHI, was 26%. After 2015, mortality was 10%. This improvement was most striking in patients with type A aortic dissection, where we had experienced a decrease in mortality by 39%. Not every patient is a candidate for frozen elephant trunk, as I'll be illustrating in his 47-year-old male with Marfan syndrome that was admitted to our institution with type B aortic dissection and malperfusion of visceral artery, as well as lower extremity malperfusion. The patient had in 1999 an ascending aortic aneurysm repair and done well with this procedure. He underwent a frozen elephant trunk on completion angiography with good result, and follow-up CT scan obtained 4 months later showed that the visceral arteries was well perfused, although the thoracic aneurysm had increased in size a little bit. I was on call one of the nights in 2017 when we got a call. The patient presented back with a ruptured thoracic aortic aneurysm. Dr. Domenico Cartera and myself took the patient to the operating room, and you see this, the aneurysm was now 11 centimeter in the chest. We proceeded by explanting the thoracic stent graft that was put in place, and all of a sudden we noticed there was an aortoesophageal fistula. I have never before seen a piece of corn actually inside the aorta. We decided to treat this patient with a rifampin-soaked graft, and we harvested fascia lata from the thigh and buttressed the esophageal fistula. Postoperatively, the patient had a very prolonged postoperative course. He was very sick. We thought he was not gonna make it, but finally pulled through. He was placed on broad-spectrum antibiotics for about 6 months. A PET scan showed that the graft, including the graft that was implanted in 1999, was now infected. After 6 months of broad-spectrum antibiotic, though, fortunately, his infection cleared. He's now 6 years out from this operation. He presented again last year in 2021 with a dilatation of his iliac artery and infrarenal aorta. The iliac artery met criteria for repair. It was a 4 centimeter. I fixed him by open repair. You can see here that I've resected his infrarenal aortic aneurysm and his iliac aneurysm, and I have bypassed it with a rifampin-soaked graft. CT scan that were obtained late last year shows that the repair remains intact. His entire aorta from the aortic roof to just above the celiac artery is replaced, and from just below the renal arteries down to the iliac artery is also being replaced. The only segment that remains is on tissue now is this paravisceral aorta, and in a Marfan patients, because we have graft above and graft below, we have a chance to offer this patient an endovascular repair, and this patient should do well. The question is now, when do we fix these patients? And the answer is right here. This is what we quote our patients about risk of rupture when they come to our clinic with an abdominal aortic aneurysm. Remember what I told you, Dr. Bergman predicted that smaller aneurysm will be repaired as the time goes by and the new problems will arise. I want to shift gear now to talk a little bit about aortic aneurysm. Here's an 81-year-old patient with a small aortic aneurysm with a very short infrarenal neck. What I call short is the distance between the lowest renal artery to the beginning of the aorta. This is our neck. This is where we'll get our seal. This was 10 millimeter. The patient aneurysm was only 4.8 centimeter in the greatest diameter. He was treated with an infrarenal device with suprarenal fixation. You can see on completion angiography that there's some contrast here. However, it is difficult to tell whether this is a type 1A endoleak because the patient has some robust lumbar arteries. This could very well be a type type 2 endoleak or even a type 1A endoleak, but because the patients are usually heavily heparinized. The dictum is that we don't chase these endoleak. We get out of the operating room, reverse anticoagulation, and scan the patient and see what's going on in the future. As we, on follow-up in 2010, you can see that this was not a type 2 endoleak, but in fact, it was a type 1 endoleak as we see here. The patient was observed, and in 2013, the aneurysm that was 4.8 centimeter at the time of repair now measures 6 centimeter in the greatest diameter. The patient's repair was rescued with a fenestrated stent graft, as you can see here, with good results. When we talk about EVAR failure, in my mind, there are really three factors. There is a patient factor, device factor, and physician factor. Patient's factor is really centers around the hostile neck, which include a short neck, angulated, presence of thrombus, tortuosity, occlusive disease, or disease progression, especially in patients with family history of aortic aneurysm. Device issues include device integrity, such as fracture, fabric tears, although these are increasingly rare because most of the devices that we currently use are either second or third, and some of them even fourth generation devices. In my mind, the most important risk factor for device failure is really the physician factor. And this is due to either lack of access to technology or training, or even knowledge, which will lead to poor device or treatment selection for the patient. Here is 4 different cases that I have shown to you. If you wouldn't be surprised if I were to tell you that the radiologist report will say infrarenal abdominal, will go something like infrarenal abdominal aortic aneurysm, measuring 6.5 centimeter in the greatest diameter, referred to vascular surgery for treatment. They'll be right about that, although of the 4 patients that I've shown here, there's only 1 patient who's really a candidate for an infrarenal abdominal aortic, endovascular infrarenal abdominal aortic aneurysm, because the rest of these patients have what we would call risky aorta or hostile neck due to thrombus. This is thrombus or calcification or other dilatations. In my experience, this makes about 20 to 40% of patients with infrarenal aneurysm who are not candidate for repair with currently commercially available infrarenal devices. The question then becomes, what is a healthy aorta? And you can ask yourself, is any aorta in the patients with aneurysmal disease healthy? And the answer is probably not. But given this, then the real question should be, what is healthy enough? Well, in my mind, healthy enough is offering a patient a repair that will outlive the patient. And sometimes this requires landing the device above the renal artery or even the mesenteric artery. Well, how do we then go ahead and do this without compromising flow to these very important organs? Because if we cover the SMA, celiac artery, and renal artery, the patient's bowels are dead, patient goes into renal failures, and within a few hours, the patient will be dead. This question was in the mind of 3 physicians from Australia, only 6 years after Dr. Perotti had published his experience, who were doing animal model by taking Cook devices, creating fenestration, and delivering them to exclude mostly renal arteries. Dr. John Anderson, also from Australia, for the first time in 1999, had a patient with a very short neck and discrepancy from renal artery, where the right renal artery was higher than the left renal artery. He was the very first person in the world to implant the first fenestrated device with a single fenestration to the left renal artery, and this fenestration had struts going across it, and the fenestration was not breached. Fast forward, in the United States, this technique was taken up by 2 pioneers in Dr. Timothy Shooter from the University of California, San Francisco, who believed that patients should be treated with branch devices, and Dr. Roy Greenberg from the Cleveland Clinic believed that patients should be treated by a combination of branch and fenestrated devices. In 2000 in 2012, for the first time ever, Cook Medical was the first company and remains the only company to gain commercial approval of a fenestrated stent graft. The device was designed to treat patients with juxtarenal aortic aneurysm just stopping shy or at the level of the renal arteries. Patients with aneurysm extending above the renal arteries were not candidate for this repair. The device came with either two fenestrations, two small fenestration and a large fenestration, or two small fenestration or a scallop as shown here. The device was designed with the idea that one size does not fit all. The procedure really starts and ends, or fenestrated stent graft starts and ends outside of the operating room with strict measurements. We use center line of flow to determine the proximal landing zone, a distal landing zone in healthy aorta. We measure the distance from the top of the graft to the celiac artery and the superior mesenteric artery, right and left renal artery. We pay particular attention to angulation or axis, the suprarenal axis, infrarenal axis, as well as aneurysmal axis. We also pay attention to the aortic tortuosity and determine beforehand where the main body will be advanced. If you look at this patient as the aorta is very tortuous here, you can see that if I were to advance the main device or fenestrated device this way, this on the right side, I would have to come here, then take this angle here, and take this angle here. However, if I were to come from the left side, I only have two curves to deal with. Keep in mind what we're trying to do. We are trying to get a device that has fenestration that are sometimes 6 millimeter in the greatest diameter. We are hoping to align them perfectly with the renal artery and the superior mesenteric artery so we can get out through the fenestration and put a bridging stent so we don't cover these vessels. We also pay particular attention to the diameter of the vessel and sheath, and particularly to avoid any tortuosity of the fenestrated component. Here is the 81-year-old male with a history of aneurysmal repair many, many years ago that was referred to me for evaluation from Duluth. The patient had a hostile abdomen, having undergone large bowel resection and had a colostomy bag at the presentation. His aneurysm had grown in size and measured the time 7.8 centimeter in the greatest diameter. At first, when I was looking at this aorta, it was really hard for me to tell where the graft was. I could see there's a stent graft here, and there's perhaps a stent graft here. I wasn't sure whether there was graft material or not at this region here. A careful review of the scallop of the CT scan, you can see that this graft is completely fractured, and the distal part has bent on itself due to tortuosity of the aorta. We designed a fenestrated stent graft. As you can see here, we're trying to come from the left side to try to gain access. This is a device, even with the stiffest wire, which is a Landoquist wire, we were not able to advance the device in this case. We switched gear and we decided to obtain through-and-through access, expose the brachial artery, got the wire snared from the left groin, and we had two people pulling a wire with the same force, exerting the same force, pulling the wire on the arm, another person pulling the wire from the groin in order to stretch this aorta as much as we can so we can advance the device. We were finally successful at advancing the device, and we repaired the patient, and he did well. In 2017, we decided to look at our own experience. This is the experience of patients that were treated with fenestrated stent graft, including 84 patients treated with fenestrated stent graft. We decided to compare them with patients undergoing open repair, with a total of 6 patients. Again, all these patients had complex aortic aneurysm, meaning the aneurysm were above the renal arteries or encroaching the renal arteries. The majority of the patient in a fenestrated group, and rightly so, were older and had increased comorbid condition. However, these patients, compared to open repair, patient in a fenestrated group had decreased transfusion requirement, decreased ICU and hospital length of stay, decreased overall major adverse event, and were more likely to be discharged directly home as opposed to being sent to nursing home. And 30-day mortality was similar between the group, at 2.4 for the FEVAR group and 2.9 for the open group. The challenge is that the current device that we have today is only designed to treat patient with juxtarenal aneurysm or patient with aneurysm that are encroaching the renal arteries. We do not have devices that are designed to treat patients with aneurysm going above the renal arteries or patient with thoracoabdominal aortic aneurysm. We know that from a publication from Dr. Greenberg, this is a patient that he repaired in 2005. As you can see, that the patient underwent a 3-vessel repair. The superior mesenteric artery, both renal arteries are stented, and the aneurysm is excluded. By 2008, the disease has progressed, and even a fenestrated stent graft is now failing. And by 2011, this repair now has failed. So fenestrated stent grafts are not immune to failure or are not immune to disease progression. Industry has really gained understanding of this concept. As you can see here, compared to earlier design, both off-the-shelf and patient-specific devices being currently in the pipeline are designed to incorporate all 4 vessels because we're trying to avoid disease progression and avoid device failure. The problem is that these devices, all the devices that you see here, with the exception of the Cook Zenith fenestrated device, are only in clinical trials. This is the Medtronic device that was recently discontinued by the FDA due to the issues with the thoracic stent graft, and the rest of them, be it a Gore device, a Cook device, or the Cryo-Jotec device, all of them, again, incorporate all 4 vessels. And they are limited to center with an IDE. Because of this restriction, we worked really hard over the last few years, and these were the initial 10 centers in the United States with an IDE. Last year, we were finally granted an IDE to start treating patients with complex aortic aneurysm who have the aneurysm extending above the celiac, above the renal arteries. 2 other centers, including USC, Dr. Suku An, and another center in Washington, D.C., Dr. Fatima, have been granted another IDE for a total of 13 IDE currently in the United States. What does this mean for us? Well, this is a 83-year-old male with a history of type B aortic dissection that was managed medically, that presented with a 7.4 centimeter Crawford extent 2 thoracoabdominal aortic aneurysm. A careful look at the CT scan of this patient, you see that all visceral arteries are coming from true lumen. The patient has 2 robust right renal artery, 1 left renal artery, and celiac and SMA, and you can see that the dissection extends all the way into the right common iliac artery. So this patient will need a 5-vessel fenestrated repair. We try to do this patient in a stage fashion to avoid the risk of paraplegia. The first stage consists of placement of a thoracic stent graft. Then we wait for about 4 weeks. We bring the patient back. We use motor evoked potential and somatosensory evoked potentials during the operation to monitor perfusion of the spinal cord during the procedure. As you can see from this repair, the patient aneurysm was successfully excluded with a 5-vessel fenestrated stent graft, and we use a Gore IBE to exclude the left internal iliac artery. There are a few areas of intense research, and these are the areas that we hope our IDE will focus on. These include ascending aortic aneurysm repair, arch aneurysm repair, repair of thoracoabdominal aortic aneurysm, and complex aortic aneurysm requiring bilateral common iliac arteries. Another area of interest is really radiation exposure. We have manuscript from circulation showing that radiation-induced DNA damage in operator performing high volume endovascular aortic surgery. Another manuscript published just last year show high incidence of chromosomal aberration in operator performing large volume of endovascular procedure, and this even include coronary angiography and total occlusion. Here is a case from Dr. Carlos Timoran from the UT Southwestern. Yeah, as you can see here, this case using fiber optic real shape or force imaging. This is a catheter and wires that can be used without fluoroscopy to fuse after fusion of the patient's CT scan and merge with the patient on the table. Dr. Timoran is now using a fiber optic catheter to catheterize celiac artery, left superior mesenteric artery, left and right renal artery. And angiography is only used to confirm the presence of endoleak, to ascertain that the target vessels are well catheterized and deploy the bridging stent and confirm the presence of endoleak. This certainly has the future, and a few other centers, I believe a total of 5 different centers in the United States trialing this device. I'll be remiss to tell you that endovascular repair is the answer to all patients with complex aortic aneurysm or aortic aneurysm for that matter. There are patients who are not a candidate for aortic aneurysm. That include patients with multiple or small renal arteries. And in our practice, small renal arteries defined as less than 4 millimeters in the greatest diameter. Patient with excessive angulation or those with early bifurcation of the renal arteries, patient with shaggy aorta, particularly as shown here, should not be instrumented because due to increased risk of embolization to not only lower extremities shown here, but also to renal arteries and superior mesenteric artery. For these patients, open repair is really the way to go. Whether the procedure is done endovascular or open, complex aortic aneurysm repair is quite an undertaking and require a strong team. Thank you again for the opportunity to present today. I'm happy to take questions.
Yes. Thanks for a great talk. What do you think of, I know there was some of the new guidelines. What do you make of size criteria for repair for infrarenal? It's pretty standard because of 5.5 because of a number of studies showing non-inferiority. What about for people with complex type 2 thoraco with a dissection? Should we be looking at 6? Should we be looking at 6.5? What do you think about that?
Yeah, that's a great question. I believe for patient with thoracoabdominal aortic aneurysm, the repair should be offered for aneurysm greater than 6 millimeters in the greatest diameter. Unlike infrarenal aortic aneurysm for several reasons. Number one, in any given patient, the aorta is bigger in men than it is in women. In any given patient, the aorta is bigger in taller people than it is in shorter people. In any given patient, the aorta is bigger closer to the heart and gets smaller the further away it goes from the heart. So the criteria that we apply for 5.5 centimeters in the infrarenal aorta should really not be applied to patients to the thoracic aorta. The threshold should really be 6 millimeters. The exception here would be if the infrarenal segment of the aorta is 6 millimeters, and the thoracic aorta is 5.5 millimeter, then you can't really have a seal without excluding the entire aneurysm. So I agree with you that the threshold should be higher. The other thing that should be taken into consideration is how difficult the procedure itself will be. So for patients, not all fenestrated and branched andografts procedure will be the same. So for patients we deem will be challenging repair, I believe the threshold for repair should be bigger as compared to patients who would be a little more straightforward. Also, the patient age should be taken into consideration. If you are 87-year-old with a thoracoabdominal aortic aneurysm, I think we have to have a serious conversation. And do you really want this repair? Because it's not a walk in the park. Yes, it's shorter convalescence, but complications can occur. And once you go under general anesthesia, it would take you a good month for you to feel the same way you felt before you were under general anesthesia. Yes.
Yes, thank you for your time this morning. That was a fantastic talk. We do have an online question from Dr. Skake. And he says, wonderful talk. Would you comment on treating inflammatory or infectious aortitis requiring surgery? We have shared a few cases.
Yeah, that's a good question. We have a patient that several fellows have now operated on who presented with Salmonella aortitis. We didn't know. This was a patient of Dr. Mirza. Actually, Dr. Skake referred to Dr. Mirza, and Dr. Mirza had placed a stent graft. So these patients are challenging. Very difficult to tell whether this is aortitis or this is an infection. And a lot of the times you go on and then put a stent graft in these patients. Once you put a stent graft, almost inevitably the stent graft, actually 100% of the time, the stent graft will become infected. And then depending on where the stent graft was placed and how sick the patient is to start with, can the patients really tolerate an open repair? Then the explantation will become the treatment modality of choice. In our experience, we like to use a cryopreserved or cadaveric aorta of the patient to bypass these, but we also know that they have high incidence of aortic dilatation with pseudoaneurysm formation or even thrombosis or complete occlusion of the iliac limbs in these cases. And in these patients, I think, to answer Dr. Skake's question, unless they are inflammatory aneurysm, and we can confirm on a PET scan that a patient really has an inflammatory aneurysm, they should be treated with endovascular repair, with open repair. The problem with inflammatory aneurysm is that once you get into the retroperitoneal, it will be completely frozen. You have a higher chance of transecting the ureter, either on the right or actually both of them, even after you have put in a stent in the ureter. So these are, again, no straight answer. I would favor open repair over endovascular repair just for the chance of an infection, and I think a PET scan should be obtained, culture should be obtained, and we involve Dr. Skake for his expertise in these cases. Yes.
There's a few more online questions.
Sure.
Should be willing to take
Yeah.
those. This one comes from Kevin, I believe, Kevin Harris.
Mhm.
It says, phenomenal talk. Congratulations on your IDE. Can you speak to ideal time of repair for acute type B with softer indication for repair that is noted on follow-up imaging?
Yes. So the timing for, we have multiple studies showing that for type B aortic dissection, if you can delay repair in a subacute period, meaning after 4 weeks, between 4 weeks and 90 days, that's the best time to treat patients with type B aortic dissection. The reason for this is most of these stent grafts are either landing just at the level of the subclavian artery, and sometimes, as you saw in the case that we just did, we did a carotid subclavian bypass and we landed it just distal to the left carotid artery. There's a higher chance of retrograde dissection. So you're converting a type B aortic dissection to a type A aortic dissection if this repair is performed in an acute phase. When the patient comes in with a dissection, fresh dissection, the entire aorta is very friable and very vulnerable. Placing a device, especially if you oversize it aggressively, can cause a retrograde dissection. If you don't oversize it well enough, I have seen at this institution where the device was placed, looked great, but the device was undersized, and as the aorta started remodeling, the device sunk or migrated south, occluded the celiac artery and SMA, and the patient presented with mesenteric ischemia. So the sizing can be tricky, and that's why we want to wait about 4 to 6 weeks before we do these. This is the ideal time where we have the lowest complications possible. So what pushes us to really fix these patients? Well, we have a number of criteria that we use to repair these patients, and I think we've gone a little bit fast on them, but in our practice, we look at the entry tear of greater than 1.5. We also look at, we try to look at if the patient has a total aortic volume greater than 40%, this includes true and false lumen, we'll go ahead and treat these patients. And if they're younger, and we think that these patients might, over the long term, develop a thoracoabdominal aortic aneurysm, as you see here, we offer them a delay repair. Yes?
All right, so the last online question, and thank you for responding to these, comes from Dr. Lesser, who says, wonderful talk. Is it most common for fenestrated abdominal aortic aneurysm to fail as a result of further aneurysm growth or a technical problem with the graft?
Great question. I had a slide here that now I wish I had kept, but I took it out. I thought I had too many slides. If you look at aneurysm disease, all comers, if you have a history of aortic aneurysm in your family, patients with family history of aortic aneurysm, or patients with aneurysm. So say, for instance, a patient comes in, they've had a history of ascending aortic aneurysm repair in the past, and now come in with an infrarenal aortic aneurysm. These patients are more likely to have disease progression than, say, a patient who has never had any aneurysm before. So for these patients, we really plan more aggressively. We try to get to more normal aorta. We are more likely, should I say, to offer these patients a 4-vessel fenestrated than a 3-vessel fenestrated device. Here is our reasoning why we offer a patient a 4-vessel fenestrated device. If we land a device above 2 centimeter, at least 2 centimeter above the celiac artery, and this aneurysm progress over time, the repair in this case is very simple. All we have to do, we just have to go through the femoral artery and put a thoracic stent graft into our existing repair and exclude the aneurysm. We can do this with the patient awake. We can do this under general anesthesia, and the patient really goes home the next day. However, if we have a 2-vessel fenestrated or 3-vessel fenestrated that is now failed, the problem becomes really complex. We have to divert to something else that I felt to put here because I thought I had too many slides, creating inner branch, because now the space in the aorta is very crowded. You have to create new branch to go inside the existing branch and extend your repair above, and these repairs are never easy. Thank you so much.